Welcome to this webinar on older people and public policy in the age of COVID-19, hosted by the National University of Ireland, Galway, Galway Institute for Life Course and Society, the Irish Centre for Social Gerontology, and the Centre for Economic and Social Research on Dementia. My name's Nora Keating. It's been my privilege to work with Professor Walsh and other members of today's panel on how lives of older people evolve across the life course and how these life courses can lead for some to profound levels of exclusion in later life. The COVID-19 pandemic has given rise to a series of critical policy questions surrounding how we view older adults and how we should support and engage diverse aging populations into the future. Today, we will explore the implications of the pandemic for major public policy topics on aging and older people. I'd like to open our conversation with an excerpt from a chapter that I wrote with a colleague from Swansea University, Maria Cheshire Allen. It's in a forthcoming book entitled Social Exclusion in Aging Societies, edited by Kieran Walsh and others. In it, we say, the COVID-19 pandemic placed older persons' vulnerability to social exclusion in stark relief. Early in the pandemic, we saw swift policy action focused on older persons. In some countries, people over age 70 were held to stricter rules of self-isolation. In others, nursing homes were locked down. Such policies afford protection on the one hand, but remove agency on the other. COVID-19 highlighted the value stances that continue to place older people as conditional citizens. From the outset, the work you will hear about today had as its goal shared understandings of late life exclusion that would help us lead to meaningful policy and practice. Today's presenters will focus on three themes of exclusion and the policy implications of those themes. The first is inequalities and exclusion. We've seen these writ large in many parts of the world in recent months, but I see them particularly in Latin America, where the economic situation has been difficult and where inequalities are long-standing and growing. Kieran Walsh and Anya Lema will address this issue. The second theme is care and carers. In Canada, the dire circumstances of older people in some of our nursing homes has been seen as a national disgrace. We've had a small policy breakthrough in my province of British Columbia, where all care workers now work only for one care facility, protecting older residents from exposure to COVID-19 and workers from the unstable employment resulting from multiple small contracts with different providers. Eamon O'Shea and Giovanni Lemura will speak to this issue. Finally, rights and representation is the third theme. We see this theme writ large across jurisdictions, where older persons are held to more stringent criteria for self-isolation and where they are placed low on the triage of access to ventilators. Nina Jorgensi and Patricia Conboy will finish with comments on this major issue. Each speaker will have 6 minutes to make their contributions, and we will follow all of the presentations then with questions from you to panel members. Please send your questions as they arise and let us know if you would like a particular speaker to address them. Kieran Walsh will close the session with final comments about forthcoming publications that provide more details on the ideas that you have heard here today. I'd like now to turn the floor over to Kieran Walsh.
Thank you, Nora. Well, I think first and foremost, all of the discussions today are in the context of an outbreak that has had a massive impact on aging societies and older populations across most of the world, and has as such produced really significant traumas around experiences of sickness, ill health, and fatalities for families, for communities, and for many nations to deal with. So I think it's really important to acknowledge the magnitude of the challenge that faced public health authorities and governments, but also the huge loss with respect to older people and other groups, of course, that has occurred as well. So then more specifically in terms of this theme of social inclusion and equality, well, my interest is in the continuum between exclusion and inclusion. And the pandemic, for me, has illustrated the need to really pay a very close attention to the many ways in which policy and exclusionary experiences intersect in older age. My focus is primarily on the aspect of exclusion, but of course policy can provide a very powerful mediating role in protecting older people from exclusion as well. But my concentration is on elements of exclusion just for today. So on that basis, what I want to bring attention to really is this idea of multidimensional social exclusion for older people in general, but also the position of older people who are members of particularly vulnerable and traditionally marginalized groups within our society. So it was very clear from the early stages of the pandemic that there was the potential for older people to experience multiple forms of disadvantage as a result of the pandemic itself. And in that way, while this was largely unintentional, it could actually strip some of the key attributes of a cohesive society that we so much value, whether this is rights and resources, whether it's opportunities and choices, or whether it's just the idea of having control of our own destiny and our own choices as well. And we can think about this in different ways. The first is really around the exclusion outcomes that can arise and stem from the sort of strategies that were put in place to control the spread of COVID-19, and that really did impact on the lived experiences of older people. And many of these have been highlighted already elsewhere, but they include the increased risk of loneliness and the increased risk of having less informal social support as a result of requirements for social isolation and cocooning. They include the difficulties in accessing and reluctance to attend essential medical appointments due to fear and stigmatization. And they include profound forms of digital exclusion where some older adults may struggle to access appropriate health and health service information. Together, all of these factors meant that older people during the period of COVID-19, and perhaps continue to do so, were likely to experience greater levels of exclusion from social relations, exclusion from services, and exclusions from participation, whether that's social or civic participation. But perhaps in a more important and more critical way, it also meant that fundamental resources such as relationships, such as services, and such as key information was eroded, which people usually rely on to negotiate these adverse risk events and to negotiate these sorts of crises that people were being faced with. Of course, in response to a lot of these tangible forms of exclusion, there were some really strong policies there to try and support older people, both from a state-led element, but also from community responses right across different jurisdictions. And in Ireland, it was certainly focused on things like the community call. On the other side, there are more tangible or intangible forms of exclusion, if you like, that take up a slightly more symbolic form of exclusion that can contribute to how older people are stripped of their multi and complex identities and reduced to just age categories. I think Nina is going to focus more on these aspects, but I think it is worth recognizing that these sort of exclusionary processes can arise from some of the discourse, public and policy discourses that have emerged around aging and older people during the pandemic. And whether that's that paternalistic discourse or whether it's the problematization of aging in terms of older people perhaps blocking essential resources for younger, healthier, and supposedly more productive individuals. So such discourses can function to devalue not only the status of older people as equal citizens, but also the sort of value that we place on their contribution and their lives in our society. The treatment of nursing homes and nursing home residents in a lot of nations during the pandemic certainly epitomizes the most severe form of this problematization, and it may even expose a more systemic collective ease at the segregation of these facilities away from our mainstream societies. The fact that many countries were very slow to count COVID-related deaths in nursing homes, if at all, can be argued to be the ultimate exclusion, stripping individual identities. But the pandemic has also illustrated the need to really consider the position of other more traditionally marginalised groups that older people are members of. In ICSG, we certainly try to conduct some work to capture these voices and experiences, including the study that's funded by the HSE Ageing Research Awards that focused on older homeless adults and older travellers. And what's very evident here is that these individuals were more likely to have a heightened susceptibility to the virus and the exclusionary impacts of COVID-related measures because of accumulated disadvantages across the life course, because of complex physical and mental health needs, and in many cases because of living in shared and sometimes inappropriate accommodation. So in sum, what I just want to really end with is that COVID-19 has certainly intensified the exclusions that older populations can face, but in many ways has not introduced new policy challenges. Issues around digital exclusion, issues around social isolation, issues around homelessness and housing were all pre-existing, as was our failure sometimes to recognise the heterogeneity of older populations, the importance of their life course experiences, and the diversity of older people with respect to membership of key different groups. So for me, there's certainly a need for a multidimensional frame like social exclusion to evaluate the impact of such crisis and any proposed responses and solutions to help support older people. And in that light, I would certainly draw attention to a recent roadmap that was published by Cost Action that a number of us are involved in, which focuses on reducing social exclusion. And certainly that roadmap still stands in terms of its focus on different actions, policy actions in different research areas and different measures that are need to be put in place to reduce exclusion for older adults. Thanks very much.
Thanks so much, Kieran. May I turn things over to Anya now, please?
Okay, hello. My name is Anya Nidema, and I'm based at the Irish Centre for Social Gerontology at NUI Galway. So my research focuses on the work-life experiences of older workers, that's people aged 50 and over, and the impact for them of policies designed to extend working life. I'm currently working on a project called DAISY, which involves 5 countries, and I'm interviewing workers in 3 different occupations, health, finance, and transport, about their work-life history and their views on extending their working life. So just before talking about the impact of COVID-19, I'll tell you about some of the important policies affecting older in Ireland, with a focus on inequalities and how they may exacerbate them. So one of the main measures introduced in recent years is the increase in state pension age, about which there's been a lot of controversy recently. So the reasons the government give for the increase in state pension age are to ensure the sustainability of the pension system because of population ageing and because people are living longer, healthier lives. So the state pension age was increased to 66 from 65 in 2014 and is due to increase, or was due to increase to 67 in 2021 and 68 in 2028. But the new programme for government proposes to defer these increases for a year at least, subject to recommendations in a report to be published by a new Commission on Pensions in 2021. So this increase in state pension age is quite steep because in an international context, Ireland still has a relatively young population with 14% aged 65 or over compared to other European countries, many of which are over 20% at this point. One of the problems with increasing state pension age so quickly is that it's a one-size-fits-all policy. So it's the same for all workers, regardless of their occupation. It assumes that older people are free to work past traditional state pension age, that there is employment for them, and that they're healthy enough to do so. However, many women and men have responsibility for caring for dependent family members, including older people and our grandchildren, and may not be free to work in paid employment. And there's a gender aspect to that, in that women are 5 times more likely than men to leave work for family care reasons. And secondly, there's evidence of ageism in relation to recruitment in Ireland and in many other countries. So it's likely that if older people lose their jobs, they may find it difficult to find alternative employment. So people in precarious employment are at risk from this. And thirdly, there's a lot of evidence showing that people in physically demanding jobs, such as construction or caregiving or hospitality, develop work-related injuries much earlier than people in sedentary occupations. So they may find it either very difficult or just simply impossible to continue working past traditional state pension age. So finally, many people will have been looking forward to and planning for their retirement at 65, and they're now forced to rely on the lower job seekers allowance rather than having their access to the contributory pension they had worked towards all their lives. So how has the coronavirus and associated policies affected older workers? So in a number of ways, surprisingly, giving the emphasis by the government on encouraging workers to work longer, those aged 66 and over were not entitled to the pandemic unemployment payment of €350 per week. So this seems quite a contradictory approach. On the one hand, encouraging people to work past age 65, and on the other, not giving them access to the pandemic unemployment payment, which suggests that they're not valued in the same way as other workers. Anyone in seasonal employment, which includes many older workers, many of those have to struggle to pay their bills, including rent, health insurance, and so on. Instead of the pandemic unemployment payment, they're entitled to the contributory state pension, which is far less. It's €248 for the full pension. But many people, mainly women, are not eligible for the full pension due to having worked part-time to fit in with caring responsibilities. So for many, the reason they're working is at this age is because they can't manage on the contributory state pension. Older workers in precarious seasonal employment, such as those running B&Bs and bus tour companies, for example, have been severely affected. In fact, they've lost all of their income from that source this year. So many women, older women living in the Gaeltacht, provide accommodation for students learning Irish, and they have, on average, lost up to a third of their annual income this year, and they may not be able to recover from that loss. As mentioned before, if older workers do lose their jobs, they're less likely to find work again for many reasons, including age discrimination. Finally, many older women work as healthcare assistants, and they're affected in the same way as other frontline healthcare workers, being more at risk of contracting COVID-19, having to wear PPE and spend more time on hygiene precautions. I won't say more about them because I know that other people will be talking about care. So I want to finish by saying, as Kieran has already said, it's not so much that it's introducing new challenges, but it's exacerbating some of the, or possibly exacerbating some of the inequalities that were there already. But COVID-19 gives us an opportunity to think seriously about how we can genuinely support older workers to work longer through imaginative, targeted policies rather than simply raising state pension age across the board. So I hope that we'll grasp this opportunity. And if anybody's interested in this, there's a book just been published at the end of February, covering this from a cost action and the whole issue of extended working life in 34 countries. So then that's available on open access. Okay, so thanks very much.
Thank you both. I think you raise important points. One of the things that Kieran says in his presentation is that there are really no new challenges in terms of the exclusions, but I think, as Anya points out, there may be some new opportunities. So let me move next to Eamon, please.
Hello, everybody. I'm Eamon O'Shea, and I'm Director of the Centre for Economic and Social Research on Dementia at NUI Galway. And in the brief time I have, I'm just going to make an argument for a much broader continuum of care for people with dementia. The COVID crisis sort of isn't responsible for that call. I think we've been looking for that for a long time, but I think it exacerbated some of the things that have been damaging in terms of the care system, not only in Ireland but elsewhere. And I think the COVID crisis is interesting because it certainly identified the fact that there is a great degree of caring about older people, not only in Irish society but elsewhere. And unfortunately, there is also evidence that in that attempt to care more, in other words, protect older people in the face of the COVID crisis, we've also become less caring in the sense that there's good evidence of solidarity, but that sometimes manifests itself as excessive paternalism, encouraging otherness, a sense of creating invisibility, and also that leads to potential diminished personhood and citizenship. And I think so. On the one hand, you have this attempt to ensure that older people are protected, but on the other hand, I think it has diminished somewhat the autonomy of older people. And personhood in particular, so my focus is on dementia, and Tom Kitwood's definition of personhood as a standing or a status that is bestowed upon one human being by others in the context of particular social relationship and institutional arrangements, never more important than in the changes that have occurred in those social conditions and social relationship and institutional arrangements following COVID. I mean, the lockdown of society, the separation of people in hospital from their friends, people in nursing homes, separation, all for good reason, as we well understand. But I think it has created certainly unforeseen consequences for people and for older people in particular. And I think that spills over not only from personhood, but it spills over into citizenship, because I think citizenship is, as we know, a status bestowed on people who are full members of a community. And I think with equal rights and similarly with equal duties that the status bestows. But I think there is certainly an issue of whether people with dementia in particular are full citizens in the context of not only COVID crisis, but whether they're full citizens in the context of respect for their autonomy, their well-being, and their sense of understanding self and their own identity, even within the sort of the Alzheimer's disease itself, or the diminution of abilities. And I think that's an issue that comes up. And I think the social model of dementia then, I think, has also been affected by COVID, because the social model of it sort of is about social circumstances, about biography, it's about creating, it's about understanding the social milieu and social relationship and connectedness. And I think that's something that's been diminished by COVID and certainly needs to be addressed in the context. And that brings me to policy frames in a sense, because looking forward to what needs to change and what we need to think about, I think the current policy frame is individual, it's biological, it's focused on residential care in an excessive way. It's focused on risk for good reason, but it leads itself to us thinking about deficits in people, and it potentially leads to exclusion and disconnection. And I think what the COVID crisis has certainly brought home to me is the need to move to a different policy frame. A policy frame that's emphasis on the social, emphasis on the collective, in particular is emphasized on a continuum of care that is focused on home, and when it's focused on residential care, it's focused on a different type of residential care than we've had up to now, and that it acknowledges that people with dementia, and indeed all dependent older people, have capabilities and are, in a sense, or continue to be, right up to end of life, to be valuable human beings with valuable things to say and valuable relationships to keep strong. So I think it's emphasized for me the need to sort of change policy or to think about different policy frames. So in the brief time left, just principles that I would say are important. I think of what this has brought home: attachment to place, and I think of particularly attachment to home, and ensuring that that attachment is strengthened in policy. I think personhood in practice for people with dementia, never more important. Person-centred care, whole sense of respect and autonomy for people with dementia. Choice is equally important. It remains important, and in particular, connectivity to others. We saw the damage done to connectivity through the COVID crisis and through separation of people from friends and relatives, and indeed right up to end of life. And I think that again should help us to focus on new ways to think about the continuum of care. So what should then finally, and the focus be of policymakers? Well, I think the ongoing combating of ageism and representation of adaptability and diversity in older age. I think that never goes away, and I think it's been highlighted by the crisis. A focus on belonging and a sense of aging in place and fostering and supporting a sense of place. The visibility of older people, because if you're invisible, I think it's easier for you to be lost within public policy space. Developing the continuum of care and making autonomy a really strong force within that is really strong. And I think embracing the biopsychosocial model of health production. I think all of this has been highlighted by COVID. Not that it wasn't there before, but I think now we have an opportunity, not only here in Ireland, but elsewhere, to think about a new model that puts older people and people with dementia at the centre of the decision-making process. So thank you, and I'll hand you back.
Thank you, Eamon. May I turn things over to Giovanni, please?
And good evening to everybody. I'm Giovanni Lamura, and I am the director of the Center for Socioeconomic Research on Aging at Italy's National Institute of Health and Science on Aging. My focus is on long-term care, and one of the areas on which in this field evidence has been more easily available is that of residential care. Although the use of different methods does not allow for a true cross-national comparability of data, last week a recent overview of 26 countries suggested that on average almost half of all cases of COVID-19 deaths were care home residents across countries. So now, no matter how reliable figures might be, it is clear that during the pandemic, interventions to prevent the contagion have either neglected this setting or were ineffective in doing so. And therefore, a first message coming out is that future public policies in long-term care sector should make sure that enough attention is paid not only to acute care, like the one provided by hospitals, but also to the long-term care sector in terms of residential care. Now, let's move, however, to the area of family care, because this is a much less visible. We have been talking just in a few seconds ago about the visibility of older people, but we have an issue of also visibility of family carers. And evidence in this area has been much less systematic on what happened during and after the pandemic in the households of very older people living in the community, including the challenges faced by their own family carers. Now, some preliminary data do suggest, however, that these groups have been heavily hit in different ways. And one aspect is the lack of information and guidance on the appropriate behavior to be adopted, which has strained many older people in their carers, causing fear, stress, and anxiety. Many family carers felt obliged to adopt very restrictive and prudent measures to protect their vulnerable family members, including foregoing regular health care and thus prompting potentially harmful self-medication. The need for support has been crucial, particularly for the many new informal carers reported in some countries who had not previously carried out a caring role, but had to do so either as a result of their older relative falling sick or due to the absence of care services during the pandemic. Another aspect is, as we have seen, the reduction in access to and provision and use of health, social, and long-term care services. We are talking about general practitioners, home care, daycare centers, transportation, respite services. All these have been restricted, and in some cases, these has raised even the ethically sensitive issue of potentially discriminatory practices when age was used as a criterion to limit access to care for other people. If we think of family care, the increase in the pressures on already stretched family networks has been reported in many countries, and sometimes leading to negative effects on social relationships. We have been witnessing a sort of refamiliarization of care, which has intensified as some older people went back to their families when it became clear that institutional care facilities turned out to be unsafe, with a stronger impact on women, so a strong gender dimension, since women traditionally do the bulk of caregiving, but have been also more frequently affected by job losses and layoffs during the responses, due to the responses to the pandemic. And related issues to that is the reconciliation of work and care tasks. Flexible working following the outbreak may have facilitated such reconciliation on the one hand, but the closure of schools and kindergartens, especially for the sandwich generation, may have exposed carers to a particularly challenging balance act, especially when a reduction of intergenerational contacts was prompted to prevent contagion. And in addition to that, social isolation, mental health issues, they were already evident in non-pandemic times, as has been mentioned before, but they have been exacerbated, particularly by those, and this is a notable group among older people and their carers, with lower digital skills, who cannot benefit from the opportunities available today to connect via the internet or other digital solutions. And these might be partly related also to a change or an impact on the patterns of elder abuse and neglect in domestic settings, since in some countries an increase has been reported in the number of calls to helplines during the confinement period. And this might have been possibly facilitated by the reduction in contacts with external professionals, as this is a key channel through which abuse is often detected. Now, I would like to close by mentioning a component that has been playing an increasing role in long-term care provision across many countries. And I'm referring here to the care workers, often with a migration background, who are privately hired by many households, sometimes with no regular contract and on a live-in basis, to support them in home-based daily care. These are actually essential frontline workers. We can consider them to be so. And they keep the long-term care sector running. In reality, however, evidence shows that some of them have been fired to reduce the risk of contagion for the older care recipients, or due to the economic difficulties in the families employing them. And in their circumstances, this means not only the loss of their job, but also of the roof under which they live. In undeclared contractual situations, some have been also forced into an even stricter confinement than that imposed to the general population, to reduce the risk of being caught outside the household during the lockdown, given their illegal condition. And so I think these are all components we need to keep in mind when addressing, from a policy perspective, the long-term care sector. And on these words, I'd like to conclude my contribution. Thank you.
Thank you, Eamon and Giovanni. I think this issue of care and caring really is a great microcosm for some of the exclusions we see of older people and their threat to personhood, of family carers and their isolation and perhaps loss of employment, of care workers who are particularly vulnerable during these difficult times. I'd like to turn now to our third theme, which is about rights and representation, and turn things over to Nina, please.
So I work for Age Platform Europe, which is an EU network of organizations that promote and defend the rights of older persons. And what I want to do today is to discuss some of the opportunities, but also the limits of international human rights law to see and discuss this pandemic. So what is international human rights law is essentially a series of obligations that states have voluntarily accepted by signing on to international treaties, and they agreed to abide by. And they create legal obligations on governments, first, to respect rights, in other words, to refrain from action that interferes directly with individual rights, to protect rights, in other words, to prevent violations of rights of their citizens by others, and third, to fulfill rights, which involves taking action, taking measures to ensure that rights are realized in practice, for example, through the establishment of a justice system, a healthcare system, free vaccination, free education, and so on. And I think that human rights is an important lens, both for the review of the pandemic, what went wrong, how to avoid future strategies, potentially some legal repercussions, especially in the context of long-term care, as is the case now in several countries like France and Spain who are looking into that. But perhaps more important for today's discussion, I think human rights is an important tool about how to build better, more inclusive and fairer policies in the future. Now, Professor Gerard Quinn says that human rights provide a mirror to society through which we can see the gap between our intentions, the commitments that we have made in these international treaties, and the reality and practice of our systems. So what does international human rights law say in the context of these public health emergencies? It said that states can derogate from applying certain rights, like our right to freedom, but they must do so by imposing measures that are established in law, that are non-discriminatory, that are necessary and proportionate, and that are time-bound. But in reality, we have seen that measures that apply to the older population sometimes failed, perhaps often failed, to respond to this criteria. So we have seen age-based confinement. We have seen age-based triage protocols, which were often imposed without considering other alternatives, without considering the implications on older people's rights. For example, the right to health, despite several warnings of the World Health Organization about the impact of long-term confinement on physical and mental health, the right to family life, to participation, to work, without consulting them. So we have seen violations of states' obligation to respect right when there was a denial to access people from nursing settings to hospital care in countries like France or Spain, older workers not entitled to the pandemic benefit like in Ireland. We have seen a failure to comply with the obligation to protect rights when states, for example, did not take early enough preventive measures, even though we knew from China that this pandemic had an adverse effect on older people. We saw states tolerating a lot of hate speech, ageist comments by politicians and journalists, social media, and others. We have seen a failure also to comply with the obligation to fulfill rights, be it in terms of failing to provide priority testing for those more at risk, such as the population in congregated settings, to provide support for people living in the community, and so on. So in many ways, older people's lives have been treated as others have said, regrettably expendable. And the director of the World Health Organization said back in April, I think, that many governments felt that COVID-19 was less worthy of their best efforts precisely because it was affecting older persons. If it was children that it was affecting, the urgency would probably have been much clearer, measures would have been taken with much more urgency, and more lives could have been saved. As a society, we would not have accepted triage protocols on the basis of race or gender, although there is some evidence that, for example, men of color are also less likely to survive from COVID-19. But at the same time, we accept as normal when decisions about the allocation of scarce medical resources are taken solely on the basis of chronological age. So these are just a few examples of ageism in our culture, in our societies, and our institutions, and our policies. Now, in principle, human rights law should be helpful to avoid such breaches, such forms of discrimination. If anything, human rights law tells us that we all have the same rights, that no life is expendable, especially if there's something that can be done to prevent it. But unfortunately, international human rights law suffers from the same biases that we as a society collectively face. So if we tend to normalize, to accept, and to trivialize the tragic cases of neglect and discrimination and exclusion that others have referred to today, international human rights law, unfortunately, is also ill-equipped to address these violations, to provide remedy, and to ensure that they do not happen again. So we currently lack a form of clear baseline, a legal compass, a yardstick to be able to see this gap between our aspirations and our practices. So we have currently no prohibition of age discrimination in international human rights law, not to the extent that we have such a prohibition for discrimination on the basis of race, gender, or disability. As a result, we tend to accept it, to accept more exceptions, and to consider it less severe. We have no obligation to consult older persons when we adopt policies that target them, when we take decisions about their lives are taken. As a result, the Fundamental Rights Agency said that only 3 EU member states have actually consulted older people or their representative organizations when they were adopting policies around COVID-19. And even those who did so in a very ad hoc, very limited way. Likewise, there's no obligation to provide alternatives to care in institutions. So these are just a couple of examples of the current gap in international human rights law. And this is why the UN Secretary General said in his policy brief around COVID-19 and older persons that this pandemic is a reminder and an opportunity to improve our legal frameworks, to ensure better protection of our rights when we're older, be it in times of pandemic, but also beyond. Because as many others mentioned today, exclusion and discrimination are not new or unique to this pandemic. So I think this is something that we seriously need to consider, both at national level in terms of reforms and improving our laws, but also at international level, because Age Platform Europe, alongside many other stakeholders, believes that we need a new UN convention to challenge the practices that keep us from living fairly and freely as equals when we're older. Thank you.
Thank you very much, Nina. May we turn now to Patricia, please?
Good evening, everyone, and thank you to NUI Galway for inviting me to contribute to the webinar this evening. I work with HelpAge International, and let me say a couple of words about HelpAge to put my remarks in context. Essentially, we promote the right of all older people to lead dignified, healthy and secure lives, and our focus is on older people in low and middle income countries. These are diverse and complex settings, and I'm obviously going to paint a very broad picture, so bear with me while I do that. There is a multilateral effort led at the global level by the United Nations to support governments in low and middle income countries in responding to COVID-19. And that works across 3 pillars: the humanitarian pillar, the health pillar, and the socioeconomic pillar. A key challenge is to ensure that older people, the risks older people face from COVID-19 are actually recognised and actually explicitly addressed in policies and plans. And this is not a high bar, but this doesn't happen automatically. And as Nina has explained and pointed out, ageism predates the pandemic. So from COVID-19 for older people in low and middle income countries, there are risks not alone in terms of health and in terms of death, and in terms of the diversion of services, health services, from pre-existing conditions from which older people suffer disproportionately, and which actually are an additional risk factor in terms of COVID-19. There are also risks in terms of food insecurity, income insecurity, reduced visibility in statistics and data, increased exposure to discrimination, to violence, abuse and neglect. And all of these reflect the earlier framework that Kieran outlined for us in terms of a multidimensional approach to social exclusion. So there's this multidimensional picture in relation to older people in low and middle income countries also, but not well understood in the policy domain. So, for example, just 23% of older people in sub-Saharan Africa have access to a pension. It's 24% in South Asia. And yet, when we come to talking about lockdowns, or we come to talking about shielding policies where we require older people to stay at home, we make the assumption that they can easily do so. In actual fact, they are participating in society in all kinds of ways. 1/3 of older women in low-income countries, 1/2 of older men in low-income countries are economically active, without pensions, without access to work, and with their families in increased difficulty. They simply struggle for income and for food. So there have been reduced opportunities also to hear directly from older people and to hear their voices during the pandemic. So as we know, group meetings have been restricted and face-to-face direct contact. And there's a much greater reliance on telephone and online communication. And this has consequences in terms of the voice, the participation, and also of older people, but also very critically in terms of the evidence base which we are developing for policy on the impact of COVID on older people. In sub-Saharan Africa, 2/3 of households have a telephone. That's households, not individuals. We don't know who within the household actually has access to a phone. And yet we would have an increasing number of international agencies and national agencies aiming to gather data from older people through the use of telephone surveys. So there are real challenges in terms of hearing directly from older people at community level. Despite the difficulties in HelpAge, we have worked hard to hear directly from older people through staff on the ground, through network members, and through the conduct of rapid needs assessments. And the kinds of risks that I have just touched on very fleetingly here have been we've heard about them and how they're playing out in people's lives. Having pointed to some of the difficulties in terms of telephone communication, I also want to weigh against that how telephone communication has been used positively to stay in contact with people who are in their homes, to provide support, but also to track how they're getting on in terms of family relationships and in terms of keeping them safe. And we have experience of that kind from a range of countries, including Moldova and Jordan, for example. So whilst we have heard a lot about difficulties, what has also come through very, very strongly to us is how clearly and strongly older people's associations and community groups are themselves key to the response to COVID-19 on the ground in terms of providing support to other older people, disseminating information through word of mouth, which we know older people like, as well as all of the other methods, and basically helping to maintain a sense of support and community cohesion. So if I take in our policy design any message from this, it is that particularly in terms of ageing and development policy, we far too easily and quickly homogenize older people as a vulnerable group. And in fact, what we need is an approach to policy design, as other contributors have highlighted this morning, that really puts older people's agency front and centre as participants in developing the response and the recovery from COVID-19 and in developing better systems and more age-friendly systems in the future. With that, I'll hand back to Nora. Thank you.
Thank you so much, Patricia and Nina. I think what you do is set these issues into these broader policy frames, particularly around legislation and how that might make a difference in the lives of older people. We have a few minutes remaining to ask some of our panel members to address questions that have been raised. And I find it interesting that the questions coming from the audience, I think, focus around what we might call the action part of how we address exclusion. So one question is, what has worked well? What are examples of what has worked well in official policy or on the ground practice to support and engage older people? And I think that's indicative of questions around, we've got a great deal of evidence. There's a great deal of highlighting of the difficulties of older people with COVID-19. Are there any examples out there of how we're doing well to address these? Who would like to take on that question? Kieran, thank you.
Okay, so I suppose, Nora, there's a couple of things that would be certainly worth noting, both in international context, but also here in Ireland. I think the first is that even though there was issues around accessing information, there is certainly a lot of clarity in messages, particularly here in Ireland from the public health side. And anecdotally, people really appreciate that because it's removed some of the ambiguities that other jurisdictions have struggled with. So I think it's worth noting that, number one, and the role of national media in producing that clarity in message. But on the other side, what has seems to have occurred, certainly on the ground level, is the sort of intersectoral efforts that have really banded together to deal with some of the complex issues that we've mentioned here, particularly for high-risk groups. So, for example, local organisations here in Galway, like Galway Simon, plus local authorities and the Health Service Executive, really had to put in place very extensive protocols to try and protect against infection control issues, try to harness new residential spaces, but also to try and attempt to facilitate online access to very intensive supports and services like addiction services and counsel services in a very, very small period of time. And what's key here for a lot of these organizations is that there is a real need to try and make sure that all the work that's been put into building supportive relationships isn't eroded through this social distancing. It doesn't undermine the trust, doesn't undermine the inclusive philosophies of these different organizations and sectors. I suppose the other thing just to mention is that sometimes we think of on-the-ground organizations within community and civil society, such as other aging-related organizations as well, and we think about them not as frontline workers, and perhaps now, through COVID-19, we should very much start thinking about them in that way. This large kind of realm of social care and community activity certainly really came to the fore during the period of the pandemic, and perhaps there's a better way to harness and recognize that sort of work.
Thank you. Yes, Eamon.
Direct voice of people with dementia, it's really important to get that direct voice into the policy process. Some of the things we've been doing at the Centre for Economic and Social Research of Dementia and have been trying to ensure that that voice is strong, and with the ASI, the Alzheimer's Society of Ireland, Alzheimer Europe also. And I think that voice is absolutely essential, that it becomes stronger and tells the story of dementia and care and carers directly to people, as well as the agencies and organisations that work on their behalf. I think that voice is absolutely central. And that paper that my colleague Fiona Keogh and Helen Roscher Brennan is in the Health Research Board Open, HRB Open, is a really good example of why and how that works. So I think for me, the direct voice is absolutely critical.
Now, who else? I'm sorry, someone else was it Patricia you were going to comment? Thank you.
Yes, thanks a million, Nora. It's echoing the points that Kieran and Eamon have made, but exactly in relation to community groups on the ground, civil society groups on the ground, they have been really important in our experience with the response to COVID. And what we have also found is where we have been able to produce guidance on how older people can protect themselves, how they can be safe in terms of managing home care and so on. It's this network of groups on the ground. When international staff are nowhere to be seen, they're the ones who are able to promote. I think the other thing in terms of systemic responses, social pensions are very effective, and there have been, some very good developments in that area with particular responses to older people or for the community at risk. And where countries had previously invested in universal health coverage, and had developed their systems as favouring primary and community care. They've been served very well during the pandemic, and there's obviously scope to build on that. Thank you.
There's a question that perhaps Nina, you might address. And the question is, we know that evidence doesn't always result in policy action, and it really is about what's the place of values in policy action. You allude to that when you made a comment about how some governments haven't put COVID-19 high on their list because it mostly affects older people. How do we get at that values level? Because it seems we can have wonderful human rights legislation and law, but there has to be a will to enact it.
Yeah, that's a tough question, I guess, and I would definitely like to hear contributions by others in this panel. I think that if there's one thing that that COVID-19 has provided us is a lot more visibility of the plight and the inequalities faced by older persons, which is something that we have not seen perhaps to this extent, at least at the global level or at such comprehensive perspective and overview before. So I don't think that COVID-19 will change our values, or it is just a matter of values, because but I think that sometimes opportunities like this one can provide more visibility and more opportunity for us to rethink our societies and to really put forward the values that we share. So I don't think equality and human rights for everyone is not a value that we share as a society, and it is enshrined in international human rights law, and it's something that we aim to promote through our policies. But in terms of prioritization and actual policy on the ground, this is where things get more difficult. On the good news side, when the UN Secretary General prepared to launch this policy brief on older persons and COVID-19, I think 146 UN member states signed on to a statement supporting this policy brief. This is the first time that at the international level, I think there's so much, agreement about the need to do more around aging and older persons through a rights lens, supporting these common values that we globally as society have. So I think there's much room for optimism there.
Thank you. A final question I'm going to ask Anya and Giovanni to respond to. It seems to me that there was some joining up of your comments. Anya's comments about how gender and employment intersect, and we see these highlighted, for example, with older workers, women also having to care for family members. And Giovanni's comments about how family carers can be put into very difficult situations where they are then isolated from any other support. How do we deal with that intersection of work, gender, and care? I mean, I know it's a huge one, but if you had, if you were able to take an action, Anya, where would you start?
I would want to give about 3 actions together. So I think the whole issue of care, of who should do the care in a society, I think there's a real need to think about that, and I suppose a sharing of the care across by gender, and I think designing employment policies that there's a really strong desire for people to work maybe 3 days a week, 4 days a week, coming closer to the end of their working lives. And I think there's a real opportunity to debate what kind of society do we want. Do we want one that is more balanced, both across by gender and by, how people spend their time and how people care for people who need it in society.
Giovanni, any other comments to add?
Yes, well, a very short one concerning, let's say, a negative example from the way the Italian government addressed the issue. At a certain stage, there were a lot of task forces set up to address the emergency period in different terms, not only from a health related aspect, but also in terms of economic consequences. And at a certain stage, they realized that the presence of representatives, not only from the older, let's say, age groups, but also from groups like working class women or frontline workers and so on, and the typical invisible groups, was so little that nothing could come seriously in that area. So I think the issue of presence within the decision-making process of representatives of all groups is crucial in implementing policy.
Thank you. We're near the end of our time. Kieran, I wonder if you have any final comments or anything you can tell us about where people could learn more about some of these issues.
I think everybody has made their comments so concisely that the best thing I can do is just to say that anything that people have referred to that they feel that people want to get access to, we will paste those links into Facebook, but also we can put them on our website or Eamon's website by tomorrow as well. And the other element just to bring your attention to is that there is a couple of edited volumes that have come out or on their way out over the next few months that certainly address some of these big policy questions about aging and older people, if not directly COVID-19 always, but actually some of them do that as well. So one is on social exclusion in later life, which is going to be an open access book published by Springer in the next couple of months. So please keep an eye out for that. And again, we'll provide information on that on our website. The second is what Anya has referenced, which is another open access volume, which looks at extended working life across Europe and tries to unpack some of those challenges. And the final one is specifically looking at the issues around rural aging and trying to develop a critical rural gerontology. And again, everybody here has, I think most people here have contributed to those volumes. So if you're interested, please look at those. They are focused on policy as well as academic arguments and academic questions. And other than that, I'd like to say thanks very much for everybody joining us both on Facebook and all the contributors as well.
Thank you, everybody, for a very stimulating hour together. Thank you to our audience for your questions, and we will formally close this webinar. Thanks very much.